Welcome back to the part 3. There is actually 10, 15, 20 minutes of class left to complete this topic. Actually, I had some issues with the internet, which are solved now. So just now I was discussing about filtration and absorption. So please remember, there are forces which act inside the capillaries and outside the capillaries. These forces are responsible for the movement of fluid, and this is what governs the fact that whether the patient is having any edema or some disease, and your medications also work like that. Give me a second, I'm getting back. So I don't know where this audio problem has started in. Hello. Yes, it has settled now. Am I audible properly now? Is there any disturbance? A lot of disturbance is coming. Yes. Is there any disturbance now? So we were discussing the filtration and absorption. In this capillary, because of presence of two important forces, that is the hydrostatic force and the oncotic force, the oncotic protein, oncotic force which is exerted by the proteins present. So what happens is we have a denotation like the hydrostatic pressure we denote by the letter P, and oncotic pressure we are denoting by the letter I. All right, so we have got the hydrostatic pressure of the capillary, PC, which we call it. It is because of this the movement of fluid occurs from capillaries into the interstitium outside. Similarly, from the interstitium, if fluid has to come in, the interstitial fluid hydrostatic pressure, PIF, hydrostatic pressure of the interstitial fluid should be high. At the same time, if you talk about the oncotic pressure of the capillaries, if it is low, then it attracts fluid from the interstitium into the vascular compartment or capillaries. If the oncotic pressure IF of the interstitial fluid is high, so it attracts the fluid from the capillaries into the interstitium. All right, if the oncotic pressure of the capillary is high, and this is what is governing of fluid movement from one compartment to the other, interstitial fluid and capillary fluid. So please remember that what are the forces of filtration. Let us try to understand what are the forces of filtration. Forces of filtration. All right, the first important force of filtration is the hydrostatic pressure of the capillaries. The hydrostatic pressure of the capillaries is directly related to the blood flow. It is directly related to the blood flow. It is directly related to the pressure inside the blood vessel. It is directly related to the blood volume. And there is a counteraction, or you should also understand that there is a entity called as oncotic pressure of the interstitial fluid. So oncotic pressure of the interstitial fluid is a force of filtration. This is determined by, I already told you, proteins present in the interstitial fluid. Normally very small amount of proteins are present in the interstitial fluid. Hence the oncotic pressure is of the interstitial fluid is actually low. Under most of the conditions, it is very, very negligible. It's a negligible factor. So these two forces of filtration. What are the forces of absorption? Let us start to understand what are the forces of absorption. The forces of absorption, exactly opposite to what is the force of filtration. That is the oncotic pressure of the capillaries, the oncotic pressure of the capillary, or you can call it plasma, the plasma proteins which are causing oncotic pressure, and the interaction between the hydrostatic pressure of the interstitial fluid. So what determines the oncotic pressure of the capillaries? It is the plasma proteins which are determining the oncotic pressure of the capillaries. It is because of a lot of plasma proteins are there, so oncotic pressure of the capillaries will be very, very high. It will be high, usually it will be high. And especially the albumin is the biggest contributor of this force. Albumin is maintaining this force. Right. Whereas in the contrast is hydrostatic pressure of the interstitium. The hydrostatic pressure of the interstitium is very, very difficult to estimate. We do not have any direct method to estimate. Actually, we do not have any direct method. We should have some indirect formula to estimate. I'll tell you what is that formula. But in most cases, it is observed to be it is 0, or it is slightly, it is close to 0, or it is negative. In most of the cases, it is negative. all right, and it is not that important. But sometimes if edema is present, if a patient has got edema, it becomes significant. How? If a patient has got edema, it can cause glomerular filtration disturbances. The glomerular filtration rate can be disturbed because of the pressure in the Bowman's space. The Bowman's space pressure, is nothing but the interstitial fluid pressure of that area. For example, if this is the glomerulus, this is the Bowman's capsule, Bowman's cup, and this is the afferent renal arteriole forming the glomerulus like this, tuft of capillaries, and this is the efferent renal arteriole. We all know this, I have already taught this. So in the Bowman's space, in the interstitial fluid here, if at all patient has got fluid accumulation in the body, at this point of time GFR may be reduced here, and thus increasing the issue of especially seen in CKD and all. So usually hydrostatic pressure of the interstitium has got negligible role. It is similar to the oncotic pressure of the interstitial fluid. So on the whole, if you see, the oncotic pressure of the interstitium is negligible effect, the hydrostatic pressure of the interstitial fluid is negligible effect. So I'll go back to this diagram which I have already shown you. So these two pressures, that is the interstitial fluid oncotic pressure and the interstitial fluid hydrostatic pressure, both these have got negligible effect onto the filtration and absorption. All right, filtration and absorption. Next, let us talk about how to calculate these pressures. It is determined by the law of Starling's equation. The calculation of these pressures is determined by law of Starling's equation. There are four forces. These are referred to as Starling's forces. And once you group these forces, which is favoring the filtration, which is opposing it, which is favoring absorption, which is opposing it. So we'll try to understand with the help of a formula QF. QF here stands for fluid movement. Movement of the fluid. Movement of the fluid is equal to K. This is filtration coefficient. Filtration coefficient, that is the capillary hydrostatic pressure plus the interstitial fluid oncotic pressure subtracted from the interstitial fluid hydrostatic pressure plus the capillary oncotic pressure. So this is the formula. This is the formula. We practically don't apply this formula. This is only theoretical point. But please remember, a positive value of Q indicates what? A positive value of Q indicates what? This parameter is higher than this parameter. Is it not? So what does that mean? There is a net filtration. A positive value means net filtration has occurred. Exactly opposite is negative value. Negative value means the net absorption has occurred. All right, net absorption has occurred. So this filtration coefficient is very, very important here, which is depending on the site we are talking about. Like for example, if you're talking about the kidneys, it is different. If you're talking about capillary of the intestines, it is different. If you're talking about absorption of various other tissues, it is different. So this is what is changes. The K value changes with the tissue which we are talking about. So this is all about the Starling's equation. Now how does it apply? How is it applied in case of edema? I told you, if a patient comes with edema, whether it is pitting type of edema or non-pitting type of edema, the peripheral edema, please remember, the peripheral edema is significant. The peripheral edema is significant if you carefully analyze the capillary hydrostatic pressure and the interstitial oncotic pressure. These two things, if you carefully, the capillary hydrostatic pressure and the interstitial fluid oncotic pressure. So the capillary hydrostatic pressure, it can increase if there is a vasodilation, is it not? If there is a vasodilation, what will happen if there is a vasodilation? It increases the blood flow. If blood flow is increased, the capillary hydrostatic pressure increases, and this results in movement of fluid into the interstitial space. Example is heart failure, all right, or sodium retention, any form of sodium hyperaldosteronism, something like that. Next is the interstitial oncotic pressure. The interstitial fluid oncotic pressure, if it is increased, if this is increased, what does that mean? It means that the proteins present in the interstitial fluid are more. Usually it is low, but it is more. For example, if a person has got thyroid dysfunction, hypothyroidism usually, thyroid dysfunction will cause proteins to accumulate in the interstitial fluid, and thus it will cause fluid accumulation in the interstitial fluid, causing the pitting type of edema. Next example I'll tell you, in a condition where there is a decreased vascular oncotic pressure. If the oncotic pressure of the capillaries is decreased, for example, hypoalbuminemia, or patient is losing albumin, proteinuria, or proteinuria, you can call, both are same. For example, as person suffering from nephrotic syndrome, losing lot of proteins. A person suffering from diabetic nephropathy, losing lot of proteins, or liver failure. This causes decrease in the plasma oncotic pressure, and thus fluid shifts from this capillaries into the interstitium, causing lot of edema, right? Say suppose a person is suffering from lymphatic filariasis. In case of lymphatic filariasis, lymphatic obstruction will cause the difficulty of these proteins from the interstitium to. So if this is the capillary, and in the interstitium, say suppose lot of proteins got accumulated, so the oncotic pressure of the interstitial fluid increases because of lymphatic filariasis, and this results in elephantiasis, that is large limbs, and difficult to treat such conditions, is it not? Because and also intestinal proteins failure to clear, and that results in pitting type or non-pitting type of edema because of increase in oncotic interstitial fluid pressure, oncotic pressure of the interstitial fluid. All right, similar mechanisms we also observe in case of pulmonary edema, and similar mechanisms we also observe in case of cardiogenic edema. Pulmonary edema can be cardiogenic or non-cardiogenic. If you remember my respiratory class of respiratory system, I was talking about pulmonary edema. In that also we discussed how these pressures are having an interplay. So pulmonary edema can be cardiogenic or non-cardiogenic. How to differentiate cardiogenic from non-cardiogenic? Non-cardiogenic type of pulmonary edema. Edema of the interstitium of the lung, you are calling it as pulmonary edema. It is very, very difficult to treat. And it is sometimes doesn't give you time to treat also. If it is very rapidly developing flash type of pulmonary edema following acute LVF or following CKD, following dialysis, immediately after dialysis people develop flash type of pulmonary edema, and patient may die because of shortness of breath. Patient has got hypoxia and hypercapnia, increased PCO2, hypoxia and hypercapnia. So this is because of a low hydrostatic pressure in the pulmonary capillaries. So if you see the pulmonary capillaries, the hydrostatic pressure of the pulmonary capillaries is low. Pulmonary capillary hydrostatic pressure is low. And if it is, so you have to differentiate whether it is cardiogenic type of pulmonary edema or non-cardiogenic type of pulmonary edema. For example, if it is cardiogenic type of pulmonary edema, what will happen to the capillary hydrostatic pressure? It is increased actually. Capillary, why? Because of increase, say suppose left atrial pressure is increased, or lymph flow is decreased, or patient has got pulmonary capillary wedge pressure, that is pulmonary capillary wedge pressure determination helps you to confirm the diagnosis, confirmation of diagnosis, and it is elevated. And how do you treat it? You give a diuretic. Whereas non-cardiogenic type of pulmonary edema, results from direct injury to the lungs, and you are calling it as ARDS, respiratory distress syndrome. The ARDS, the adult type of respiratory distress syndrome, adult respiratory distress. Here there is direct damage to the capillary epithelium. Because of this, what will happen is, or because of some sepsis and all, what will happen is the pulmonary capillary wedge pressure is normal, is it not? There is no, or sometimes low. So because the hydrostatic pressure in the capillaries is either low or normal. The pulmonary capillary wedge pressure that you check it clinically, it is low. So here what should be the treatment? The treatment should be treat the underlying cause. Diuretic is not going to help. Treat the underlying cause. All right. Most of the times you should ventilate the patient with a positive pressure ventilation. I told you what is positive pressure ventilation. You see my old classes of go back to the respiratory system classes. I will try to understand what is positive pressure ventilation. Already I taught you. So this is how you differentiate the non-cardiogenic type of pulmonary edema from cardiogenic pulmonary edema. Cardiogenic pulmonary edema. The last point of today's discussion is how to differentiate the blood volume from plasma volume. So we use this terminology loosely, thinking that blood volume and plasma volume are equal. Let us see what are the differences, if at all any difference is there. Please remember, blood volume represents the plasma volume plus volume of RBCs. It is the plasma volume plus the volume of RBCs or cells present in the blood. Whereas plasma volume is, what do you say? Plasma volume is nothing but it is the blood volume that is devoid of cells. Without cells, if you remove the cells, you get only plasma volume. That is the plasma volume. All right. So how do you determine blood volume? So blood volume is equal to plasma volume 1 minus hematocrit. What is hematocrit? The volume of hematocrit is nothing but hematocrit means volume of RBCs. Hematocrit. Hematocrit is volume of RBCs. So please remember, if the hematocrit, say suppose it is 50%, in a patient it is 50%, say suppose. So you can say that it is 1 minus 0.5. Is it not? So the blood volume will be plasma volume, that is 3 liters, divided by 1 minus 0.5. That comes to around 6 liters. So if the hematocrit reduces by 50%, normally the hematocrit should be above 75%. If the hematocrit reduces by 50%, the blood volume will increase, will become double. So nearly, if hematocrit decrease, blood is half RBC and half plasma volume. Blood volume is nothing but it is the half RBC and half plasma volume. That is what you will have to understand. Normally, the blood volume is estimated as 7% of the total body weight. 7% of the person's body weight. For example, if a person is 70 kgs, so the blood volume is equal to 4.9 liters. Is not 7 into 7. 70%. That is 70%. 7% of the 70 kgs. Nearly 5 liters. Nearly 5. So blood volume is nearly 5 liters. Whereas plasma volume is nearly 3 liters. Please remember. So the distribution of IV fluids, if you are administering IV fluids, what will happen? The vascular compartment, the whole of the IV fluid is entering the vascular compartment. Which IV fluid remains in the vascular compartment? It is the blood, the plasma that you are giving, and the colloid type of fluids. They remain in the blood compartment only. I'll draw this diagram and show you. So we have got this ECF. So we started with this diagram and now we are ending with this diagram. Draw with another color. So say suppose this is the ICF and this is the ECF, and here we have got a capillary membrane like this, and this is the blood, and this is the interstitial fluid, ISF, whatever it is, interstitial fluid. So whatever IV fluids you are giving, say suppose you are administering the patient blood, or is it visible? Right here. Say suppose you are giving blood or blood products like platelets or whatever it is, plasma or packed cells, all right, whole blood, and colloids. They remain inside this compartment, blood compartment. Whereas if you are administering the patient with saline IV fluids, all right, they remain, the IV fluids will remain in the interstitial fluid compartment and blood compartment. They enter into it. All right. So please remember, this is how the fluid exchange occurs, and fluid exchange depends on filtration and absorption. We have discussed in this class the different parameters of filtration and absorption, and how the blood volume is different from plasma volume. This is what was left. So we have completed the chapter. If you have any doubts, please let me know through your email or chat. I'll be happy to help you. I'll be happy to explain you again. Thank you very much.